Thank you for the opportunity to speak today. I feel really honored, and I'd like to start my talk to ask a question. How many of you guys know your lipid levels? No, it's all right. How many of you guys would know your troponin level? Wow, one, okay. So here's the thing, and that is true science. About 40% of people that go to the ED and have a heart attack have completely normal lipid levels. Lipid levels do not really indicate whether you're at risk for a heart attack or not, or just to a certain degree. While troponin is an enzyme that gets leaked out of your heart when your heart is under duress, whether it's a heart attack, congestive heart failure, electrical disarray, whatever. But troponin is the best proxy to determine whether you're in good cardiac health or you need help. And that's kind of one of the paradigms that is going through my talk today and that I wanted to talk a little bit. So the title is Ultrasensitive Testing and how this would fit into telehealth. So I've been working in telehealth a little bit before. I worked for a company called the Lifecore, now Cardia. They had the first clinical grade ECG on an iPhone. It was a great idea. Unfortunately, it didn't pan out fully because we pushed towards consumers too fast and did not really try to integrate the clinical capacity, but it was a good idea, especially for people that had arrhythmias or problems with the heart to kind of self-monitor. Now, what I learned there is that there's a couple of applications of telehealth. There's certainly the diagnosis or the early diagnosis. There is the monitoring of disease. And I think what's fairly new and what's coming is the rule out of disease, which I think will be as important as the diagnosis or the monitoring of disease. And I will show you why I think that is. The company that I'm working for right now is SingleX. It's a global immunodiagnostics company established in 2004. And what SingleX has done is we have developed an ultra-high sensitivity immunoassay platform. So we can really measure down to femto levels, picograms per milliliter, very, very low. And this is important because some biomarkers, not all, some, exist at very, very low levels in a healthy state. And this is kind of a chart that I think is to a certain degree a game changer. When you look at that, this is kind of the statistical distribution of a biomarker. It is troponin in that example. You have a level of a biomarker that clearly indicates disease. If it's lower in the middle, then it's at risk. And if it's very low, that means you're at a healthy state. Now, most of the platforms today, most of the medical devices can measure up here, at least in the immunoassay range, in the red range. They can definitely rule in a disease and say, you have a disease, we need to do something now. That's acute. It's usually too late because we have to do something and it's usually major. If you can measure very, very low, and you can measure in the green range where you're healthy, this opens up the application for something completely new. This means I can baseline a patient, and then I can monitor you, and I can see if these biomarkers start creeping up, that something is about to happen, and that I need to intervene before it is too late. And that's the whole paradigm behind ultra-high sensitivity platforms. And whenever I hear the argument of, ultra-high sensitive platforms have too many false positives, I'm very confused about that because there's a certain threshold. If you're above the threshold, you have something. If you're below the threshold, you have nothing. And the only variation here is actually the correlation of variance, the precision that a platform can measure. But false positives certainly shouldn't be an argument why ultra-high sensitivity platforms should exist. So again, this is very important to understand how this might fit later into telemedicine, that if you're capable of measuring biomarkers at a healthy state, you can baseline people, you can monitor them, you can do preventative medicine, and you can rule out disease. This is a chart that just shows how many key opinion leaders we work with. It's not that important. This is a chart that shows the typical evolution that we underwent as a biotech company. We had a really interesting technology, and then first you use it in a research use only application. Then you bring it into a CLIA lab. In the CLIA lab, we have developed a fairly broad menu with high sensitivity markers where we can partner with telehealth companies. And then the last step you usually do is you go into IVD grade. You really try to make a platform that you can distribute in hospitals and in reference labs so that they can use and measure it. So now we come to troponin, what I talked about. Troponin is traditionally a marker that is used for the definitive diagnosis of an AMI, an acute myocardial infarction. When you go to the emergency department and you have the typical symptoms, radiating pain, shortness of breath, dizziness, they suspect you have a heart attack. And then they keep you in the ED, and then they start measuring your troponin. First they try an ECG, but an ECG can only, I think it's about 35 to 40% of heart attacks can be identified with an ECG. The rest has to be done by troponin. And usually the troponin is at a range where it's not very clear. So they keep you in the ED, and they measure again, they see if it rises. At some point they do an angiography. And when you look at the statistics, it's fairly interesting because depending on the geography, about 50 to 70% of the people that go to an emergency department and think they have a heart attack or have a suspected heart attack don't have one. They ate a bad burrito, I don't know, problems in their arm, but it's not a heart attack. And so they keep you 12 to 15 hours in the ED, do a battery of tests, have a lot of emergency doctors focus on you, and in the end they discharge you because you don't have a heart attack. So it would be great if you can, with one measurement, rule out a heart attack and just say, you're fine, something else. And so cardiac troponin is the closest proxy to cardiac health that is known by now, and traditionally it's used to rule in a heart attack. And till about 5 years ago, no cardiologists believed that a healthy subject has troponin in their bloodstream. And we were the first ones who could measure troponin in 100% of healthy subjects. And that means that now you can baseline somebody and say, this is a healthy range, and if you deviate from that healthy range, something is wrong and something needs to be done. This is, again, the lab where we prototyped and tested a lot of stuff. And here comes the actual, the key topic of my talk. Now, we have developed a Lab Central platform. It's launched in Europe. It will be launched in the US, where troponin is the first application. But what we thought would be really, really helpful for rural areas, for telemedicine, if we could develop a point-of-care platform that has the same clinical performance as our Lab Central analyzer. And that's what we're currently doing. By the end of the year, we'll have a prototype that can measure down to 0.1 picograms per milliliter. So as a reference here, the healthy range of troponin in a healthy subject for males is about 1 to 5 picograms per milliliter. For females, it's about 2 to 7. And this point-of-care platform will be able to fully measure down with a very, very low correlation of variance, meaning a very, very high low-end precision. It's the size of a toaster, 15-minute turnaround time, and it's cartridge-based. So you take a finger prick, put the blood into the cartridge, put the cartridge in the point-of-care device, and within 15 minutes you have the result. And how we believe this will fit and potentially can revolutionize cardiac care and telehealth is that once the platform is CLIA waived, you can have a patient at home, they can have a point-of-care device or some kind of outpatient clinic or whatever kind of small institution. And if a patient has symptoms, you just need one finger prick And within 15 minutes, you know either no disease because troponin is low, or troponin is at the risky range, so that means something needs to be done, or troponin is high enough that you say, oh yeah, we have an acute case here, and we need to bring this person into an ED as soon as possible. And you will have the typical components of telehealth. You have the sensor at the home setting that will be operated by the patient if the system will be CLIA waived and approved for home settings. You have a data transmission to some kind of clinical capacity where a physician, cardiac nurse, maybe in the future artificial intelligence, who knows, but some clinical capacity will make a decision, and then you have the feedback back to the patient what needs to be done. And this is our vision. This is what we're working towards and what we see could become reality in about 3 to 4 years from now. Thank you.
Thank you so much, Thomas. I guess any question?
So a couple of quick questions. So if you look at these American College of Cardiology day guidelines, troponins are noted to be the biomarker of choice for acute coronary syndrome. But we know that in troponin assays, typically for chest pain rule out, you have to do that Q 6 hours, Q 8 hours, depending. So, I mean, I'll leave it to you to answer how just doing one troponin would be able to detect acute coronary. And then the second point is, you know, maybe using scores like TIMI risk scores or GRACE scores in conjunction with your troponin assay to risk stratify patients who may be having unstable angina.
Sure. I have a couple of answers for your first question. Number one, the Europeans are ahead of us. The Europeans have established in 2015 at the VSee, the European Society of Cardiology, a so-called rule-out arm. So for the first time in the diagnosis, in the differential diagnosis of a heart attack, they have a diagnostic decision arm that goes out and it says, measurement of troponin at presentation of the patient in the ED. If the measurement comes back at or below 5 picograms per milliliter, discharge out. And we have a couple of studies out there that show that we can rule out a patient with one single troponin measurements, because the low-end precision is so high that you have about, at 5 picograms per milliliter, you have probably about 3% CVR, which is very, very low. So when you measure 5, you have 5. And the Europeans have established that after doing a couple of pan-European large studies, so we think that the Americans will follow at some point in time. Now, you're right. If the value is above 5 picograms per milliliter, you do, every hour you do a measurement, and then you look at the slope. And if the slope creeps up below a certain gradient, you also get discharged. If it creeps up at a higher, you're at risk, and nobody knows exactly what happens. You're in the gray zone, and then they keep you. But at least you can rule out a huge chunk of patients, and in that sense, really take that workload away from the ED without having any liability, because you know they are in what has been established as a healthy range. That's one thing. The second answer was about risk stratification. It depends a little bit on what you wanna show. Is it an unstable angina? Is it a heart attack? Is it a blockage? And what we believe will happen, and this takes quite some research and more evolution, is that you will have to use troponin signatures in order to put people in clusters. The absolute value, the slope over time, and then probably measure 2 or 3 data points to come to what I would call a signature. But that's in the future. What's established right now is that I have a very clear cutoff value. If you're below that, you're okay. You don't have any cardiac problems. Did that address your questions?
Thank you.
Thank you.
For your post-acute care, or when they're at home, you're talking about going home, and a patient shows back up or they're home and they're complaining of pain, we look at the troponins. You know, if it's a post-CABG, 10 times evaluation, and post-PCI with stent, you're talking about 5. So how would this play into those who are post-MI and evaluating whether they're having an active MI after the fact?
So the question is, how would troponin measurements play into a patient that has received a stent?
Correct. If they've already received the stent and they come back with chest pain, do you have a different cutoff value for your test to determine if they're actively having another?
As of now, this is unknown territory. There are no studies out there that show that. So we will have to do a lot of studies to show how troponin will rise or fall after somebody has received a stent, because, I mean, the assumption is probably that your biology, your biological infrastructure has been changed quite dramatically. And we don't know what kind of impact that has on troponin.
So I have a question on the medical-legal aspect of this. Like the troponin is not just a screening test. Basically, you're doing for some reason. The patients who have a chest pain, are you predicting something, you order the troponin on that. So let's see if that patient's troponin came very high. Basically, essentially, we are wasting 15 to 30 minutes of that patient who can be very critical, having acute MI, and can reach to a center, and essentially we are losing that 30 minutes on that patient.
So what's the question?
The question is that, you know, for those 30 minutes, we wasted actually for that patient to reach to a center, you know, who has acute MI. So we can be legally liable, or if something happened, if this patient has acute MI and died, we will be liable for that, you know, because we kept that patient at home waiting for the troponin to come back.
I think this has to be captured in medical guidelines, and the more sensitive devices you have, my guess is that the actual threshold to make a decision, a clinical decision, will change. Right now, when you look at most of the platforms that are out in the ED, it's mostly Alere, iStat, they have 40 picograms per milliliter. At that point, the cardiologist or the emergency doctor says, this is a definitive diagnosis of an AMI, send him to the stent lab. Before that, it's more interpretation. And the interpretation is, as you say, I measure one troponin value, I measure it half an hour again, and it starts rising fairly quickly. Then the suspicion is, this is either an AMI or a developing AMI, we need to do something. But you're absolutely right. The best of the worlds would be if you can agree on a very low absolute level, and you can measure that level within 15 minutes after the patient comes to the ED or at home. And we hope that is the future, because with that device, that point of care device, it is so sensitive and so easy to operate, it should be possible.
Okay, Thomas, how fast do you feel like how fast could that home device could be?
It's 15 minutes turnaround
15
time.
minutes.
From finger prick into the cartridge till the results gets transmitted to any kind of clinical
do you feel like that can
decision
even
maker.
be shortened down to, like, you know, just 5 minutes? The reason I'm thinking is even that when you do this test, if you came back, if you wait for that positive, you could be rushed into the ambulance during that, you're losing time. Like.
I mean, you can always try to shave off time, but 15 minutes is pretty fast right now, because you have to incubate the sample, you have to wash the sandwich assay, but it's I mean, we're working on different ways with higher affinities, so it's conceivable that you can shave these 15 minutes further down. And of course, it would be great if it's 5 minutes or 2 minutes. Yeah.
Got it. There were.
So your presentation is interesting, but it's very simple and basic in the sense that, you know, you're trying to replicate an emergency room in some ways, or an urgent care, but as you know, there's not one data point that's checked in an emergency room: blood pressure, all the vitals, pulse ox, the exam questionnaire of the patient. Some of that you could do with telehealth, but I think there's quite a bit of due diligence that needs to be done to take this further. So one troponin, is not going to be enough to figure out what's going on with the patient. I think that this could be potentially, as was alluded to, very dangerous tool to have patients trying to diagnose themselves with acute coronary syndrome at home. I see the value, and I think it's brilliant, but also very dangerous at the same time. So my recommendation would be to tread very carefully in this space and make sure you're discussing this deeply with cardiologists and the experts to figure out how one data point is just not going to be enough. I mean, obviously you could do like a Lifecore EKG monitoring, remote blood pressure monitoring, and then implement that all into. But the idea of replicating an emergency room, yeah, okay, fine, they're diagnosed or ruled out, but there's quite a bit of liability here.
I would agree with you, certainly on diagnosing AMI. That's kind of a little bit more complex. However, the rule out of an AMI is much simpler. And if your troponin is in a healthy range, your heart health is okay. You will not have an AMI. That can be, and this is actually, that's what the Europeans do. They just measure troponin. If it comes back at 5 or below 5 picograms per milliliter, it's done. You're discharged. So I agree with you that ruling in an AMI or diagnosing one,
I don't think it's that simple.
I've talked to a lot of European doctors, emergency doctors about that, and that's how they implement the guidelines.
I had a question that's kind of in the middle. So what if, I mean, let's say the patient thinks they might have to go to the emergency room. You could see a patient maybe just being so concerned that even though what you say is true, maybe they still want to go to the emergency room or call an ambulance. So have you thought about putting the devices in an ambulance to do that?
That's also a utility that you can think about, yeah? Mm-hmm. In the end, what this will be, and I agree with you that it will take quite some time and quite some more studies to validate it, right? But what this will be highly distributed testing in very different environments. And you try to kind of pull it out further and further from an ED in order to make sure that only the people go to the ED that really need an ED.
Just one more question, one more comment. Fine, the troponin is negative. They don't have an MI, but they could have an aortic dissection. And that maybe the troponin, usually sometimes the troponin is positive with the dissection, but it may not be. And so there, you could potentially find that with high blood pressure. That's why remote blood pressure monitoring EKG is useful. But again, just if it was simple as one blood measurement and everything is fine, then there's no need to have a board certified emergency room doctor or cardiologist evaluate the patient. So I think it's a little bit, it's interesting, a little bit early, and I think there's a lot more that needs to go into this, but I'm sure you're looking at it. But I'm not against this. I think it's fascinating.
No, and I fully agree with you, and the kind of first horizon we see is to have this device in the emergency room under the supervision of an emergency doctor. Absolutely.
I would agree with that in urgent care as well. Even I work part-time with some community health centers. I think we'd be interested in something like this or piloting that. But at home, I think that's a different story. But I could see that.
This is kind of my vision totally far out, right? To be very clear. This is not a claim that I'm making here.
No, I think it's interesting.
I just had a quick question on whether this applies to the pediatric population. You know, sometimes in newborns or even young children, they may have congenital heart disease that have not been detected before, like an anomalous left coronary artery, for example, may have symptoms that are not like an adult would have, but they're nonspecific. I do realize that they test troponin in children. So the first question was, are the reference ranges the same for children as compared to adults? And number two, is it being used for young kids?
So far, we have only established healthy ranges for male and female adults. We don't know about children. And my guess is, this is just my guess from the research that I've seen, that you probably have to start developing troponin signatures, where you have several data points that show you a rise and a fall and that are multidimensional in order to cluster different patient populations into the right bucket. And that will take time and very, very large studies, to be clear. This is only a start, right?
So you seem to have spawned a bunch of worried physicians, and I'm just another one.
I see how you worry. I like that. That means you care about your patients. That's good.
So I'm kind of stuck on the early part of your presentation where you were talking about the ultra normal levels or very low levels. And it strikes me it's like lots of other tests we've experienced over the last few decades of my career where because it's really all hung on the Bayesian statistics involved in decision making, because all the testing, all the data we have is in patients who present to an emergency room and that kind of model of decision making, like you say, the rule in and rule out. Mm-hmm. Whereas at the very low levels, since we're testing for different circumstances, there may be a whole new statistical set of normal values and stuff that we'll have to uncover. That will take a lot of time. I think you recognize that, but I've just seen, over my career, I've seen a number of tests proposed, and then they fall by the wayside because we have not paid attention to the real Bayesian statistics, the inferential process in which they have to be used rather than just cutoff values. So I assume that'll be addressed as if you're successful in carrying this forward.
I fully agree with you. Again, number one, this does not pertain to every biomarker. There's only a class of biomarkers that are at very low levels at healthy status. Number one, right? So there's other biomarkers you don't need ultra-high sensitivity, very clear. The second thing is, I picked troponin because from our perspective, this is one of the most well-described biomarkers. We have measured, we have done a study with 650,000 patients to establish the healthy ranges and to establish the low levels. And I think 650,000 is pretty good for a clinical study. I mean, I have not seen that many clinical studies that are that large. So in that sense, I feel confident that we have, statistically speaking, established the right healthy ranges for male adults and female adults. Now, granted, there's more to come. For instance, children. We have no idea how troponin looks in healthy children or children with cardiac problems. We don't know. We haven't done it yet. But for male and female adults, I think with 650,000 patient samples, that's usually enough statistical power to come to a conclusion.
Well, it's enough statistical power to come to just the dispersion of normal values. But then when you're trying to make decisions on that, it may be different, because then you're going to have to know the probability of disease, and if you're talking about very low probabilities, then it changes the test characteristics.
I agree with you, and what we have done is not just measure the troponin, but we have done the follow-up over years with the GP and with the internal medicine doctor in order to see what this value really means and how it develops. So I agree with you.
Thanks.
Any other questions? Can I ask you, this might be very silly, so don't lie. I guess, based on the data you have seen, do you expect maybe when the 10, 20 years, I could do my test, get a signature, then based on my signature, this would give me predict that within, let's say, next 6 months or 12 months, I will definitely not have, like I could just go
Yeah, whatever I'm going to say is going to be wrong now, guaranteed, guaranteed. I mean, when you look at other examples in medicine and you look at signatures that predict something, the hope is that with a troponin signature, like troponin values every 2 weeks, in a very specified patient population, that you can make a certain statement for a certain amount of time, right? But then you're exposed to an environment that can change everything in the blink of a moment, so kind of, it's very difficult. It's a very
Not that
dicey
hopeful.
question.
I would love to have that, of course. Just say,
Yeah.
next 12
Yeah.
months.
Milton, you will not have a heart attack in the next year. Start drinking, shooting coke, whatever. You'll be fine. Yeah, that's what you want to hear. I know that. Yeah.
It would be nice to have census guarantee.
Yeah. And if anything goes wrong, we come to you, and we're going to sue you for 17.5 million. Yeah. No, but I mean, this is only a start, to be very clear. But I think it's a great start because it changes the paradigm to a certain degree, and you can now, with higher confidence, and really look at people and say, hey, are you in a healthy range? Are you at a risky range? Or do we need some acute intervention right now? And to me, that is progress. That is something that didn't happen at this level before. And I see medicine as constantly evolving and moving forward, and it's small steps, and we need to do a lot of studies to have enough data to feel confident that we're doing the right things. And I personally, and this might be going against the grain of certain people in the audience right now, I do believe that we will need MDs, that we will always need MDs, that we cannot replace everything with artificial intelligence. I want to have somebody with 20, 30 years experience looking at me and saying, I don't know, let's try this and then see how it works. But that's my personal opinion. This is all aids and support in clinical decision making. So I do believe that we need clinical capacity to make the final decision.
Okay, any other questions? Okay, thank you so much, Howard, for that, really.